Hello everyone and welcome back to my channel. I hope you've all had an amazing week. So today I'm going to be talking about heart failure because it can be one of those tricky topics to discuss with a patient, and as well can get a bit tricky to manage as well because there are so many different treatment options. So I've had a look at some resources to simplify it for you, so hopefully it's a bit easier to understand and manage. But before I do, don't forget to like, comment and subscribe to my channel. It helps me know that you're enjoying this and helps me keep going to keep making more clips. Also, if you stay to the end, I'll give you tips for some resources to give to patients and to use for your own benefit. So anyway, let's get on with the video. So what is heart failure? In sort of simple terms, heart failure is a combination of symptoms and signs that suggest a decreased efficiency of the heart. Now, it affects quite a lot of people in the UK, with about 920,000 people affected, could even be more today, and about the average age of diagnosis about 77. They believe that this is just going to keep going up because of an increasing ageing population and increased rates of obesity as well. So, how does heart failure present? Well, first of all, the symptoms that someone may present with is that coming in with breathlessness or a cough. They may have noticed ankle swelling as well, going up the legs. They also can present with orthopnea, which is breathlessness lying flat. They may also present with palpitations or notice that they've suddenly gained quite a bit of weight, or even they can present that they've generally lost weight as well. And some of the signs that you might be looking out for is a raised JVP, where if you've got them on the examination couch and they're looking slightly to the left, you can see a raised pulse here, like double pulsation. You could see swelling on their ankles, and especially pitting edema, where you press on the legs and it leaves a little indent. You may hear bibasal crackles on the chest, which is fine crackles at both the lower bases of the lungs. You could even hear a wheeze throughout the lung as well. In terms of when you've got someone with heart failure as well, you can actually grade them. There's the New York Heart Association grading for heart failure, where there's stage 1, where they're absolutely fine, they can do all their normal activities and heart failure doesn't affect them much at all. There's grade 2, which is where they start to get it on sort of physical exertion, doing quite manual jobs. And then there's grade 3, which they're getting symptoms, just doing mild exertion, so just very minor jobs. And grade 4 is the worst severity, where they've got symptoms even at rest. So how do we investigate heart failure? Well, the main way is with a blood test called BNP, and what that is it's a hormone that is raised when the left ventricle is stretched, and depending on the level will depend on how soon they need to be seen. So levels less than 400 indicate that heart failure is unlikely. You need to look for an alternative diagnosis for their symptoms. Between 400 to 2000, they need to be referred to be seen by a cardiologist and have an echocardiogram within 6 weeks. And any level that is above 2000, that is actually indicating a poor prognosis, and they need to be seen quite urgently by the cardiologist, so they need to be seen within 2 weeks. Now, before we move on, just a couple of things to be aware of as well. There are certain conditions and medications that can falsely lower or raise the BNP level. So first of all, medicines that can lower the BNP level are medicines like beta blockers, ACE inhibitors, angiotensin II receptor blockers, and the aldosterone antagonists, which they're the medicines like spironolactone and eplerenone. And certain conditions that can falsely raise the BNP level is if their age is above 70, if they've got a left ventricular hypertrophy instead, a thickened left ventricle, if they've got ischemic heart disease, if they've got tachycardia, if they've got hypoxemia, CKD, sepsis, COPD or cirrhosis. So another investigation that is recommended to get done is an ECG as well, and other tests you could consider is a chest x-ray and bloods to do a full cardiovascular workup, such as UNEs, LFTs, lipid profile, thyroid function test and a full blood count. So moving on, you've done all your investigations and you've said to the patient that you likely think the diagnosis is heart failure, and they'll come back and ask you, being like, well, what is heart failure? Something that can be a little bit tricky to talk about at times. So what's recommended to discuss about is to explain that the heart is like a pump, and in heart failure this pump is reduced, which leads to the fluid building up, causing the symptoms. Also tell them as well that there are treatments available which help improve symptoms and improve prognosis, but be honest with them that the prognosis is uncertain, but many people do live for many years. And the British Heart Foundation has resources online that are good to give to the patient that help explain heart failure in more detail so they can be fully informed. So when they go to the cardiologist, have their investigations done, like the echocardiogram, if it is heart failure, they'll normally say it's one of two types, either heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. But what's the difference between them, and how does it affect the patient? Well, heart failure with reduced ejection fraction is the commonest type, where the left ventricle is stretched and dilated so it can't pump as effectively, and this is the type of heart failure where all the medications help improve survival for the patient, and this is the condition where we can give medications to patients that help improve survival and prognosis. In heart failure with preserved ejection fraction, there's actually a different pathology where instead of the heart being dilated, instead the heart muscle has become quite stiff, so not as much blood can fill in the heart when it relaxes, but the heart still has the same power when it contracts. And because of this backflow, because the heart can't fill as much, that's what causes sort of fluid leaking out, causing the swelling in the legs and the breathlessness. Now, for heart failure with preserved ejection fraction, the main treatment for it is with low dose diuretics like furosemide. They recommend sort of 40 to 80 milligrams to help get on top of symptoms. Fortunately, with heart failure with preserved ejection fractions, the other medications have not been shown to have any benefit in these patients. So moving on to managing heart failure with reduced ejection fraction, the first line is to aim to get a patient on both an ACE inhibitor and a beta blocker. Now obviously this can be quite worrying, like just putting two medicines on at once that both can lower blood pressure, which can then lead to the patient becoming quite lightheaded. Don't worry, the guidelines say start off with one and titrate that one up to the maximum dose before introducing the other. But then that obviously leads to a question of which one do you start off on first? So the guidelines recommend that you do it based on clinical judgment. So for example, you'd prefer an ACE inhibitor if they had diabetes or if they're having signs of fluid overload. And as you know, that if a patient can't tolerate an ACE inhibitor, for example, they get the common side effect of a dry cough, then you can try an angiotensin II receptor blocker instead, such as losartan. Now, if you assess the patient and you heard a heart murmur when listening to the heart, then that is the main thing where they advise to avoid an ACE inhibitor until they've had an echocardiogram seen by the cardiologist to decide if they're safe to have it or not. And then as well, I know there are lots of times where people may think, I can't introduce a beta blocker if they've got signs of peripheral vascular disease or COPD. The guidelines recommend that you can still introduce it even if they have peripheral vascular disease, diabetes, interstitial lung disease or COPD. The only ones to be cautioned about are the asthmatics, which you would leave it for the cardiologist to decide, as there are certain cardioselective beta blockers, but again, they're very specialist and better to leave it for the consultants to decide if they are to go on it or not. If there are signs of fluid overload, such as quite a bit of swelling in the ankles or fluid on the lungs, then you can introduce diuretics as well. So first one we tend to use is loop diuretics like furosemide or bumetanide. Just remember as well, you need a baseline kidney function blood test, and then whenever you introduce one or increase the dose, to get a kidney function test done again in 2 weeks to make sure they're tolerating it and not having the side effects. Now, out of the loop diuretics, I would normally start with furosemide. But here's a top little tip that I've heard from a cardiologist, that if you've got someone who's got quite extensive fluid, especially being on furosemide, or even some fluid around their abdomen, or just not responding to the furosemide, then it might be that it's not getting absorbed properly because they've got some gastric edema. Now this is where bumetanide tends to work a bit better, as it's absorbed better by the body even if there is gastric edema, and conversion to conversion is 40 milligrams of furosemide equals 1 milligram of bumetanide. But it's a little tip that I've learned, and I have used it with a couple of patients, and they have had dramatic improvement when I swap the type of diuretic. Another treatment that we tend to miss out on, but patient can be referred to, is what we call cardiac rehabilitation, where it's service where they get emotional support, exercise support, and further education as well, which these have been shown to improve survival in these patients as well and help with emotional well-being, as at the end of the day as well, it is a chronic condition that affects their life, so they're not as fit or active as they were before, which can have an emotional toll on anyone. And that's something we need to remember and focus on as well, is not just the patient as a person, but mentally, how are they coping with these symptoms? How are they coping with this diagnosis? Now, I'm sure many of us have seen that even during like hospital rotations or when someone has been discharged, that some of them will say, oh, I've been put on a fluid or salt restriction. Now, the guidelines recommend that there is no need to have a fluid or salt restriction unless they have a dilutional hyponatremia in their bloods. I've personally never had to put someone on a fluid or salt restriction, and case in point, the guidelines are just not recommending it anymore. Now, these are some extra treatments to make you aware of if you see them on the patient's medication list, that they may be on it, but these are specialist initiated medications, and they are medications such as amiodarone, ivabradine, sacubitril valsartan, hydralazine, digoxin, and even the SGLT2 inhibitors such as empagliflozin. So I know some of you may be wondering as well, will there ever be a time that I need to admit a patient? Well, this tends to go with any patient we assess them if we're concerned that they've had a very rapid onset, or if they are quite clinically unwell with extensive edema and abnormal observations such as low oxygen sats, low blood pressure, where we are worrying they're quite unwell with this and they've got decompensated heart failure, then we would send them in. So that's it for today's video. I hope you enjoyed it, and just like I promised, I'll give you the resources that I use. So I used RCGP learning module, nice guidance, and then of course there's the British Heart Foundation for the resources to give to patients as well. I've linked them all down below in the description, so you can go have a look for yourself. And anyone looking for something to do to get some CPD points for your portfolio, the RCGP module is really good and got some extra resources for patients when they reach the palliative stage of heart failure. And as always, don't forget to like, comment and subscribe. Lets me know that you're enjoying this content, and also if there is anything you want me to cover, then comment down below and I will have a look and do future videos based on them. I'm also on Instagram where I post a bit more regularly, so if you want to follow me on there, it's up here, but it's GP Made Easy. Well, that's it for today guys. I hope you have an amazing week, and I will see you in the next video.